So currently, when I'm providing maintenance therapy for patients, given the robustness of the data and multiple trials, lenalidomide remains the agent of choice. So it clearly has a dramatic impact on progression-free survival for patients with myeloma. And that's not only in the post-transplant setting, but that's also in a non-transplant setting as well. There's a clear improvement in progression-free survival. So lenalidomide is the standard of care. As far as presentations at ASH 2018, I would argue again, that ixazomib is another option for patients. But, again, the progression-free survival was not as robust as what was seen in previous lenalidomide trials, so I think ixazomib maintenance is something that will be relegated for those patients that are intolerant of lenalidomide in their initial induction therapy. We talked about Alcyone earlier, and again, progression-free survival appears to continue to improve with longer follow-up, and I think that's largely due to the fact that daratumumab was being given kind of in a maintenance setting after the initial induction therapy for these newly diagnosed transplant-ineligible patients. So it'll be very interesting to see, new data emerging on the use of daratumumab in a maintenance setting. But I think, where we really struggle at this point still is the patients with high-risk disease. So these are the patients, whether you put them on lenalidomide, ixazomib, bortezomib, daratumumab, they're going to relapse much faster than you would like. And those are the kind of patients that probably are going to need a combination maintenance strategy, and it's going to be very important in the years ahead, to do those studies.